course Abbott Nutrition for having me to moderate this session for today. It's a very important topic as far as we're talking. We heard a lot about weight loss and obesity, and when we're talking about obesity, I think body composition is one thing which is commonly overlooked or neglected, and body composition discussion is very important as of today. So we have two eminent panelists with me today, Dr. Amit Gupta. Can I have his slide, please? Can I have, okay, fine. I can introduce him that he is the chair of the IDF task force and of diabetes. He's from Greater Noida, eminent diabetologist, and he's currently being most eligible candidate for the post of Secretary General RSSDI. And I think that okay, so I think I take that opportunity to introduce him to the audience, and we have Dr. Altamas Sheikh, who is a good friend, colleague, and it's creditable that he's not in good health, and in spite of that, you can just show them the hand. He's from the hospital to this stage, and I appreciate that, and I hope I would not pester him a lot. So because Dr. Amit has another session in the other hall, we will relieve Dr. Amit before Dr. Altamas. So we will be having all the questions with him before. So coming to the discussion on diabetic specific nutrition. So we know that there is a difference between nutritional formula, nutraceuticals and standard formula, protein powders, Herbalife and DSN. So what is the difference is what we need to understand from today's discussion, and is there a need of having a DSN into our prescriptions ever? So I begin with this patient who has a body weight of 114 kilos and underwent a bariatric surgery to 60 kilograms, then again had a rebound to 83 and then was put on semaglutide. Again the weight fell down to 78 and he is trying very hard to maintain the weight. So this is a common scenario we come across, whether it's diabetic, non-diabetic. And we know that with the weight loss, there is a significant amount of muscle loss also occurring. So I can start with the first question to Dr. Altamas, and I can both of you all can take the question. What do you think can be done for such a patient where sarcopenia is a concern when there is a massive weight loss occurring and there is a yo-yo weight rebound occurring? So what is the thoughts?
I think that's a very prototype case that you've shown, madam. Very, very important that we see usually. So anybody who's had a surgery, there is a chance of weight regain by around 20 to 35% within 1 to 2 years. That's what is seen. That was followed by giving GLP-1 RS semaglutide over here in this case. And on that, the patient lost around 5 to 6 kg and then there was a plateau. So what can be done for such type of patient, which is a post-bariatric on GLP-1 RA sustaining a plateau effect? A, we look at what is happening with the lifestyle, what is the patient doing, eating, sleeping on time or no. B, it's going to be very importantly the nutrition, the diabetes specific nutrition that needs to be given in such patients, and how do you modify that? We will take it up in details in upcoming questions. C is anatomic. Is there a reanastomosis? Is there a gastric fistula which is formed? Is that the surgery has leaked out into something, the stoma, etc., that the patient is regaining weight also needs to be looked into. So it's a big thing that we need to look from all the prongs, and most importantly it's going to be a diabetes specific nutrition, and I'm sure you have a lot of questions on that. As we move ahead, we'll talk in details on that.
Yeah, so we're talking about DSN. So Dr. Gupta, can you throw light on what is this DSN? What is diabetic specific nutrition? Is it different from the other nutraceuticals that are available?
So that's a very important question, and starting from where Altamas has left, in the era of the obesity and the weight loss programs which are happening, the drugs which are available now for the weight loss, we know that whenever there is a weight loss, there is a muscle mass which is lost as well. So there are two important things which are very, very important to protect this muscle mass. And one is the strengthening exercises. We know that a person who is losing weight has to do strengthening exercises. And second is to support the nutrition. And the nutrition, as you already know, that you can't increase many of the calories because they are already on the GLP-1 or they have undergone the bariatric surgery. So you have to give nutrition in a condensed form. And that nutrition is again a high quality nutrition. So diabetes specific nutrition consists of a formula, you can say, which has a low glycemic index suitable for the people with diabetes. At the same time, rich in protein, high quality protein, rich in all kind of MUFA and the PUFA and the, you can say, rich in fiber as well, and the different micronutrients. So such kind of preparation can be used to give in a scenario where we are trying to protect the weight, trying to protect the sarcopenia. At the same time, we want to enhance the quality of the nutrition.
So I agree with Dr. Gupta that DSN actually differs in terms of the composition. If you can see this slide, it's a slow release carbohydrate blend with fiber, and there's a high quality protein, there's a fat blend which is helpful for the heart, and with micronutrients, sometimes it's lactose and gluten free, low GI. So all these factors are taken into consideration. This is not true with all the protein powders that we use. So whenever you're writing any nutritional formula, it's better to see these contents, see whether they are more preferred for diabetics. And of course, this can be used as tube feeding in pregnancy lactation also. So that's an advantage that it can be used across the spectrum. And more so, there are a lot of clinical trials which have shown that they are beneficial in terms of glycemic control and weight management. So Dr. Gupta, what is your view on glycemic control being achieved through DSN? So what's your experience also?
So it is important to understand two things here when we are talking about the glycemic control. So one of the principle which we follow is the calorie restriction. We want to initiate a calorie restricted diet, and here there are two things which are important to understand. One is supplementation and one is replacement. So I use diabetes specific nutrition as a replacement when we are trying to achieve good glycemic control, or also for the weight loss as well, because the idea here is not to supplement but to replace. So you are trying to replace a meal, whether it is a partial replacement or whether it is a complete replacement, and this way you are trying to minimize the calorie intake, and at the same time you are supporting the nutrition, quality of the nutrition you are supporting. For example, if a person is having diabetes and you are, then probably you would like to replace one of the meal with some of the protein component. Maybe depending on the doses, you can, if the half replacement, then you can say 3 scoops of the protein, and if it is a full replacement, probably 6 scoops of the protein can be given, and complete meal is replaced. So this is how the replacement is done. But partial replacement, sometimes half of the breakfast and then half of it is replaced by the protein.
Your views, Dr.
Yeah, I think I agree, but I would like to add over here that DSN for whom means as per ADA 2025, it's for all patients with diabetes with or without obesity. That's an important line and a take home from this panel that all three of us would like to give. Second is, I think very importantly, these have been validated and well tried in a lot of trials, for example, Look Ahead or in direct trial. So in Look Ahead, we had nearly 8.6% weight loss in the first year approximately. And I agree with Dr. Amit again that semi-replacement, you can give either a semi-replacement meal or like a snack replacement, or you could also give a full replacement meal, for example, a lunch or a dinner, depending upon what the patient needs, what is the patient's requirement. So this is not like, DSN also is not like one size fits all, but most importantly, how you would cater it to that particular patient, and it works wonders, both for A, your control of diabetes, and B, even for control of weight.
So let me take a poll. How many of you all are using meal replacements in your practice? Any poll, raise of hands? I can see only one hand. So I think meal replacement is a very good option. In fact, this is a very good option where I'm treating kids, where I can't give drugs, where I'm treating adolescents, where I'm treating pregnant women. So I think meal replacement has to be a part of our prescription, especially when we are talking about diabetes. Yes, sir, please.
Yeah, every patient of mine, irrespective of whatever he comes to me for, I advise one boiled egg every day. I actually write on my prescription and I tell them 365 days. Okay. So this is the best from what we were shown, on the slide. So I would call it first class protein, not high class. And the GI, the carbohydrates, this would be wonderful. And for those who don't know, I may just add that there is only one thing that the egg doesn't contain. It doesn't contain vitamin C.
So I love eggs, so I can agree with you more than...
Sir, totally agree with you, but we have a large number of population who doesn't take eggs, and this is a very, very common problem. So
87% of Indians are non-vegetarians, and those who say they are whatever, I don't want to go into details.
No, sir, I am not going because...
they take eggs. People take eggs. You advise and they will take.
So I agree with you totally, but I also have an argument to make that one egg doesn't suffice the protein requirement. So again, my second question to all of you is how many are using protein supplementation in practice? So there are two ways you can use protein. You can use as supplementation, which doctor mentioned that you have to supplement with one egg every day, but it's not enough for a 60 kg person to have one egg. So I think you need to understand the protein requirement of every individual, that is the dry weight protein requirement. So if you want to have a simple calculation, it's a simple formula, 23 into height in meters, that is, suppose my height is 1.63 meters, so I multiply 23 into 1.63 into 1.63. It's a simple formula for me to know how much protein I require. So if you are able to calculate that, by the way, one egg contains only 6 grams protein. So it will not suffice for a person like my weight. So you need to understand, and supplementation is a need. So I use meal replacements as well as I use supplementation. You need to understand which to be used where. And of course I agree with doctor that you have to advise at least the non-vegetarians can have egg, the vegetarians can have paneer, the homemade one, because there's a lot of hype about the outside paneer also. So that's the easiest you can ask your patients. So coming to the same question again to Dr. Gupta, how much of this formula should be used, should be advised, and what is the quantification? Like sir said one egg, what would you advise in terms of the meal replacement? What is your experience with practice?
So I think this is very well described in the slide also, and I will agree with this because it depends on the condition of the person. For example, if you are giving as a full replacement in a person having diabetes as obesity, then probably you are giving 1 to 2 diabetes replacement, DSN specific replacements in a day. If it is a normal weight, then uncontrolled diabetes, again then probably one meal replacement or the half meal replacement. Underweight, again this is a condition which is often encountered in some of the diabetes patients. So here you are adding it as a supplement, where you actually maybe you would like to make the patient weight gain as well. So here you can replace even 1 to 3 units per day can be also one of the replacement formula in this.
So again, how many of you do a body composition analysis in your clinics? One hand. So this is essential part which Dr. Gupta mentioned, that not all underweight are metabolically and in terms of lean mass healthy. So we need to also have their body composition analysis in mind when you're advising about proteins. But definitely I agree with you that the weight of the patient is to be taken into consideration when you're thinking about supplementation, not only for proteins but also the macros and the micros. So I think everything needs to be put in a holistic fashion. Dr. Altamash, you have, yes, please.
I would just like to add one thing here, because now we are using a lot of SGLT2 inhibitors, a lot of GLP-1 and even GLP-1 plus GIP. The weight loss, most of our patients are having some kind of weight loss nowadays. So here it becomes more important to do the BCA, because it gives you an idea that even if a normal BMI, you will find that the fat distribution is much and the protein mass is very, very low. So and most of the time these patients will come to you and that, doctor, we don't want to lose any more weight because our BMI is almost 23, 24. But that time you need to say that distribution is actually disturbed. So BCA tells you that distribution.
Right, and taking it from here, if any drug you are on, for example, in this case it was semaglutide, and if a person has lost 10 kg, and out of that 10 kg you've done a body composition, out of 10 kg, if more than 2 kg is your protein loss, then you've had actually protein loss. So that means that this patient needs more protein than you would even think of. So if you look at, do we have clinical evidences? Yes, we absolutely have. How much we should give? 1.4 to 1.6 gram per kg body weight. Taking Dr. Krishnakant sir's line ahead, one egg is a first class protein. It will give only 6 gram per day. But we need to give, for a 50 kg average woman or man, we need to give nearly 72 to 75 grams of protein. So it would be in each meal roughly 20 to 26 gram of protein, which will be given by the DSN formula. Now, without going into controversy, which madam said, and I agree, into veg, non-veg versus, DSN is vegetarian, DSN is first class protein, it has got fibers. So there is no issue of undigestibility or bloating, etc. is all been taken care, and it also provides leucine. So, a lot of things are covered with DSN.
So I agree with both the panelists, and I think when we are talking about protein supplementation, it's important that every meal has a portion of protein. So you see people going to the gym in the morning having a massive portion of protein. That is not going to work for the person. So you need to distribute it equally into every meal component, and that's why the role of meal supplementation, the with protein. So what practice I follow commonly is that I tell the patient to begin a meal with a meal replacement or a meal protein shake, which can be 1 spoon, 2 spoons. So it becomes additive because most of the vegetarian people eat very less quantity of protein because few items are available for protein supplementation, and there it really works wonders. Second important point which our panelists have highlighted is that body composition analysis. We are talking about weight loss. The maximum amount of fat in the body is also in the muscle. So when a person is losing fat, he is losing fat from the muscle, and the muscle is also thinning out. So it is not that isolated fat is going out of the muscle mass is bound to go down, and that is why there is a role of resistance exercises as well as protein supplementation while the patient is on weight loss therapy. So these 2 points important. So Dr. Gupta, do you want to highlight on the clinical evidences, the look ahead trial or any other evidences to suggest how it benefits diabetics or the glycemic control and variability?
I think Altamash has already spoken about the trials look ahead as well as the direct trial, and he has mentioned that in both the studies and in many other trials also it has been seen that there is a improvement in the A1C, there is an improvement in the fasting glucose levels as well as the postprandial glucose levels, and there are studies which shows that sometime time in range, which we talk about in the nowadays, so TIR also stabilizes. So we see benefit of the weight loss, if you are able to maintain the weight loss, then it is certainly the additional benefits you get. So DSN help, as you see in this slide, there is a reduction in 0.9% in HbA1c, fasting plasma glucose level, there is a reduction by 19 milligram per deciliter. So most of the parameters there do improve whenever we are adding DSN.
I want all of you to see this slide. It's 0.9% HbA1c fall, which is equivalent to a DPP4 inhibitor, a SGLT2 inhibitor. So just meal replacement causing a change in HbA1c, a properly given meal replacement. I think this slide highlights that it is equivalent to the drug therapy causing HbA1c fall. So I think if you have a drug which produces a HbA1c fall of 1% plus you add this, you're directly likely to get a additive benefit of the addition. And not only that, it does help in reducing fasting plasma glucose. It's more seen when patient is replacing the night meal with the meal replacement. So we have seen that evening meals replaced with the meal replacement is known to give a good control of fasting also. So Dr. Gupta just mentioned about the benefits in terms of glycemic excursions are reduced, cardiometabolic risk is reduced, the symptoms are reduced, the energy levels are drastically improved, and the satiety level increases drastically when protein intake is increased. So that is why the carb intake comes down, which also reduces the fatigue in the patients with diabetes. So this is what was studied in the look ahead study, and they found that nearly 7% weight loss occurred with use of 2 meal replacements in a day, and there was a 1.1% HbA1c reduction occurring over a period of time. So it depends of course on how many meals have been replaced. So it is directly proportional to whether 1 meal was replaced, 2 meals were replaced, and whether the replacement was followed as an ideal protocol. Like most of the patients tend to undertake the protein supplementation when it comes to cost and cost saving. So quite a few are intolerant to the protein supplementations also. So this is what Dr. Altamash was saying, that the glycemic variability reduces significantly. So you can see that the excursions of the blood glucose come down significantly when you're thinking about DSN usage. So this is about the satiety that I spoke about. Yeah. So then what about your use of DSN, both of y'all, in patients who are taking GLP-1, because we are talking about a molecule producing massive weight loss. So what is your experience and what would you comment on?
I think A is, as I said earlier, it's very important for us to have DSN for all our diabetic patients irrespective of weight, A. B is a good DSN formula will prevent sarcopenia when started with GLP-1 RAs or GLP-1 RA plus GIP-1, both the current molecules that we have. And with this preservation of mass that we see, we can of course give a better outcome of that particular weight loss, because we are looking at visceral fat loss, we are looking at bad fat weight loss, and be very, very careful. I think, ma'am, what we have recently seen is not just Ozempic face, but we are seeing Ozempic vulva and Ozempic vagina. So I think that's an important part. People are putting out a lot of allegations against the drug, because the drug was supposed to only make you lose weight and not at visceral parts, but not at the parts. So I think you have to tell all your patients when you put them on GLP-1 RAs, but do not forget, if you do not tell the patient about high protein diet, if you do not tell the patient about DSN, then it becomes medico-legal, even stronger case. So DSN has to be spoken for all, and as we discussed, it's going to be around 1.8 gram or 1.6 gram per kg for that particular person, especially so in vegetarians A, B in women, and C in elderlies, where you are giving this kind of weight loss, especially fat loss, for a good cardiovascular, diabetic and obesity outcomes.
I will just add, Altamash, our patients are also getting smarter, and many of them now, they come whenever we are putting them on GLP-1 or you say tirzepatide and all, they will come and ask that you have not given the protein. So even if sometime you mention, they will come, doctor, where is my protein, where is my vitamins, you have reduced my diet, I am not eating anything. So how I am going to survive? So this is a very natural question, and you have highlighted very well that it is important to protect the muscle mass. And just to add, though may not be the part of this discussion, but the strengthening exercises or the resistance exercises, they play a very, very important role.
Yeah, so Indians are specifically known to be sarcopenically obese. So they do have a sarcopenia in it. And beyond that, if you are going to go in for weight loss therapies for these patients who are already sarcopenic, you're likely to expect more muscle loss, and you're likely to expect more fatigue coming out of the way. So whenever we are advising weight loss therapies, whether it is diabetic or non-diabetic, there are resistance exercises, there are DSNs to be advised, and there is a proper nutritional balance to be explained. Now, I think unfortunately we as doctors have been lagging behind in advising these three components, and I think it's high time that we start treating obesity also holistically rather than just thinking of one single molecule as a medication. Any questions to the panelists? Because we'll have Dr. Yes, sir, please.
Madam, I want to ask.
Please come up to the mic, please, sir. Yeah.
Ma'am, I will make a move.
Yeah,
So
thank you, Dr. Gupta. It was fantastic. I hope the question is not for him. If it's for him, you have to answer that and go.
If the patient is not diabetic, a normal patient, we want to reduce about 10 kg. I want to know what are the dietary restrictions and what precaution one should take when you are giving a medication. You said about the dietary restriction in the evening. So I want to know what should be the dietary restriction and the medication what you give.
Yeah, so Dr. Altamash will take this. Thank you, Dr. Gupta. Thanks for that wonderful discussion.
So I think as I heard the question, you said 10 kg weight loss and does not have diabetes, right? Right. So I think the best ways for such people is, first is always lifestyle modification. Second is again a lifestyle modification, and third is again a lifestyle modification. Beyond that comes your drugs. Now what comes in lifestyle modification is first your changes in the food, right? Which could be around 40 to 50% of carbohydrate, 20 to 35% of protein, and the remaining 15 to 20% of fat. Now in this, because we are looking at weight loss, and as we know that Indians do have sarcopenic obesity, we would be giving a much higher protein content for food in these people compared to others. A. B is give fiber at least 40 gram in a day for a 2000 calorie diet, for example. And also look at hydration, because if hydration is not given appropriately, weight loss would not happen. C3 is sleep. Minimum of 7 hours of sleep is very important when you look at that. Fourth is your walking, at least 60 minutes a day, whether it is you give it high intensity interval training or you give just a simple walking, depending upon the comorbidity that your patient has, which details we do not know right now. And also look at gratitude and stress reduction. Now gratitude is very, very important, which people do not follow. Even if they understand, they still fail to do that. And stress reduction, whether you do it in the form of meditation, you do it in the form of sleep, you do it in the form of a good habit, you do it in the form of a act of kindness, or you do it in the form of breathing meditation like yoga. So in simple words for your patients, it's your khana, pina, chalna, sona and shukrana. These 5 things very easily make you lose weight. Beyond this, if you've tried for 1 month or 3 months, and if you want to add something, then you look at the comorbidities. You said your patient doesn't have diabetes, but what about blood pressure A? What about lipid cholesterol B? What about urine ACRC? What about a gallstone over there? What about a MASLD, fatty liver over there? What about osteoarthritis? So then you would choose a drug which is going to help you to lose weight with that target. But believe me, we've had a lot of patients coming with directly pens of semaglutide or tirzepatide. Doctor, I want this, you please tell me that I should take this, and at the end of the day it comes out that the patient needs LSM more than just the drug. So it is an individualized thing, it cannot be a blanket statement over there.
So I think you can go back and see the drug label. Just a minute, sir. So the
No, we would not advise to skip the meal. We would give a meal replacement, she said. Instead of the full meal, you would give 3 to 4 scoops of diabetic specific nutrition, the composition of which she showed in her second slide.
And what should be the rate of reduction of weight? Is there any formula?
Yes, it should not be more than 1.5 or 2 kg per month. If it is more than that, then it is a rapid weight loss. If your patient is losing more than 1.5 kg per week, then it's a rapid weight loss. And rapid weight loss, like rapid weight gain, is pathological. So patient will get into a lot of other diseases. So always give a realistic expectation, not more than 0.5 kg per week, irrespective of the urgency that the patient is telling.
yes, sir. Please.
Thank you, Altamash, for very nice advice on losing weight, that you need to take care of holistic thing, then looking at the whole of sleep, stress reduction, gratitude. That is wonderful. Now,
Thank you.
Now, regarding, we need to convey to the audience what is a good DSN, what is a good nutrition formula, because these companies are marketing. There are many, I don't want to name them. They are marketing, and even gyms are providing high the protein content. So that needs to be conveyed to the audience.
Superb. So you joined a little late. As I said to the gentleman over there, this slide was shown. This was the second slide for the session.
No, I was there.
You were there. Okay.
But the question is, we need to name the name. If it is not contraindicated, if someone is not sponsoring it, then you need to name that this is the DSN which is recommended by doctor, by everybody who wants you to be in the good shape, not those who are marketing it for the sake of marketing.
So
Agreed. So I'll reply to that.
I can answer
Okay.
this because I am here because I have been convinced with the molecule that I have been using for past 20 years. So I have been using when Abbott had Glucerna coming up, and this was the data from the Look Ahead study. The Look Ahead study used Glucerna as a molecule. Glucerna is no longer available. It's now as Ensure diabetes protein. So I can definitely tell you that that molecule has been tried, tested in trials across various centers in America, and they have shown, this is the data from the same trial, the Look Ahead study. It has shown that as you replace the number of meals, this is the kind of change that occurs in the weight, and 7% weight loss over a period of 1 year. It's a dramatic figure. 7% weight loss you will not get even with Orlistat, sir. So I think it is a good formula as far as the proven studies are considered. I don't say the others are bad. They don't have literature to support. I don't know. I can't comment on that, but nevertheless I can tell you that this molecule has been tried. It has been tested, it has been studied globally, and we have literature available. The Look Ahead study is a fantastic example on how intensive lifestyle modification with DSN can really help. So, anyways, I think.
So
yes,
I think
please.
it's 11:15.
Yeah.
We may
Yeah.
need to close the session over here, but I'll add on to that answer. Since you said, can you tell the brand name? So I think I agree, madam, that Glucerna SR was there. Then Ensure, we have Ensure Protein Plus also. And I think if you want to really know that, my request to the company is that, can we have a semi-replacement kind of a dose for today, 12 o'clock before lunch, today 5 p.m. before lunch, tomorrow 11 a.m., so that the semi-replacement is tasted by the full audience, and then we take it from there. Because the more, it's not an OHA or an insulin or a SEMA that we need to take ourselves. It's nutrition, as we discussed earlier, and it's a healthy nutrition, and it is more of a DSN which will help even otherwise. So I think that's a good feedback, that they can have a small sip of semi-meal replacement dose, which will, so it's like a B2B directly for you. Thanks.
I think the take home for today's session was that you need to think about nutrition first. Second is you need to think about protein supplementation, because we are really protein deficient. Even doctors are protein deficient for that matter, not only the lay people, but we need to think of that. As we grow in age, our muscle loss is faster than the bone loss and the fat loss. So we need to be more concerned about sarcopenia as we age. And thirdly, you need to be very conscious about use of right supplements, because you can't use any blanket supplement because my friend is selling a protein powder, I can't take that. It has to justify the right composition. It may cause harm. We've seen the over proteinizers also in the gyms, and that has been really toxic to the kidneys. And I think we need to be very judicious about nutrition. Nutrition, it was a field of nutritionists for long ago. I think it's high time we need to know as doctors what is the real nutrition concepts. And second important point is, it's high time we start seeing fat as an organ rather than a mass. So we should see fat beyond BMI. We should see fat as an organ of adipose tissue, adiposity as a marker of dysfunction, sarcopenia as a marker of dysfunction. See the body composition analysis. Verify that that body composition analysis justifies the use of a proper DSN. And that is going to really make a lot of difference to the lives of our diabetic patient, obese patients, and the treatment is not going to go. One more thing I would like to highlight here, Dr. Altamash also, all the drug labels mention that you have to use all these drugs as add-on to nutrition. It is not the drug plus nutrition. We write diet and exercise before drug comes into. So no drug is going to work if you don't advise on proper nutrition. So I think it's a job of every doctor, not only a diabetologist, to advise on proper nutrition, exercise. 4 exercises for obese patients. One is flexibility, second is resistance training, third is calorie burning, that is the aerobic one, and fourth is mental health exercises. All these 4 exercises done either in rotation, it's important. Addiction prevention, commonly food addiction, social media addiction, couch sitting. These 3 are the commonest addictions today. These have to be prevented. So standing, movement is an important thing. So these addictions are more making people more vulnerable for obesity, and that is the way we should focus on. So I think Altamash very nicely portrayed the important 5 pillars of management of obesity, and I think the discussion has at least incited some thoughts about nutrition and exercise and advice on that. Any questions from your side, advices, opinions? Yes, please.
Yes, so both are important. DSN will be a specific and a separate part of the meal of the day or a meal replacement. And while you are having either breakfast or a mid-morning meal or lunch or dinner, that can be your portion controlled. And when you control that portion, so we never say eat less, we say check your composition of food. Right, so 30 to 40% of a fiber, followed by 30 to 40% of protein, then followed by towards the end maybe 20-30% of a carbohydrate. That is how you would say, keep your plate over there. And in that 30 to 40%, you can make curd as one of the daily ingredient compulsorily over there, which will also give you pre-probiotics along with proteins.
Yes. please.
Ma'am, you told us very helpful session, but you told about the only obese people, but who's they are having a low weight, how should they change their lifestyle modification?
Yeah, so in fact, BMI should not be the criteria for starting any DSN or nutritional supplement. It should be based on your body composition analysis. If you can't, you can use simple markers like waist circumference. You can use the insulin resistance markers to get a clinical diagnosis. Most of us as Indians are viscerally adipose and we are sarcopenic as an average population. So you can also write a blanket prescription, but it's not justified legally. So it is better to do a body composition analysis, see the lean mass, see the fat percent. See, fat will reduce only when your protein will go up. And secondly, complex carbohydrates are known to reduce the fat mass, but pure carbohydrates are known to increase the. So your dietary composition will change based on your body composition analysis. So I would always recommend, see, I can just ask in the audience, how many of you think you all are obese? Okay, how many of you think you have healthy fat? This is why, because we have not done our body composition. You understand? So I need to know, see, you are normal weight. You clinically look normal weight. But I can assure you that you may be metabolically obese. Unless you do a body composition analysis, you cannot say my fat is healthy. So today everybody goes and does a body composition analysis. You may trust the machine or not, but at least it will give you a rough idea. It's like a glucometer. It gives you some comparability. So you can do that sequentially. In fact, we have started a campaign now with our organization. We have started distributing a measuring tape to everybody. 5 rupees ka tape deke, every year you keep on monitoring your waist circumference. And see that a 1 inch increase in waist circumference is known to increase 5 diseases. You understand? So it's simple tactics which are really going to work as far as body composition. Yes, please.
Can you suggest some supplement for the muscle gain?
Yes, Atlamash, you can take this.
There are many, I think. I think before you go to supplement, look at it from your natural foods point of view, okay? So you can have all essential amino acids, for example, except vitamin C, but for example, egg. Now, that's again a controversy. Egg, a lot of people tell that this is now considered as a plant-based protein. So now if you don't want to enter even that, then you have DSN already in place. We have given you the names already some time back, right? So 3 scoops to 6 scoops of almost double of that, maybe twice in a day, in addition to your meal that you can give, right? So if, for example, if your patient is around 50 kg and wants to increase weight to around 60 kg or so, then this person should be having at least 75 gram of protein a day, which should be coming from first class proteins. Now that becomes a calculated dietary supplement to be given, distributed across. And that should be around 20-25 grams per meal, including your semi-meals replacement or in your mid-morning samples. So it all depends how much the patient is able to take. A lot of people may not be able to even digest that much. So you need to give fibers accordingly, both soluble fiber as well as insoluble fiber. So it's a long discussion, A. B, you should also put the patient to resistance exercises, because only giving diet here and not doing a body composition and not doing a muscle strengthening exercise is going to put into trouble. Now, while you're doing this, do not put the patient to too much of a cardio, because otherwise the muscles will not be formed. They will lose a lot of muscle over there. So depending upon the strength, whether lady, whether a man, or whether a boy or a girl, you would start with, repetitions, which is going to be more important. For example, a 3 kg, 4 kg or 5 kg dumbbell, do in the morning 10 to 15 reps into 3 sets each, and maybe in the evening for a different muscle. So it's a full coaching. So in our clinic, we have a dietitian, we have a physiotherapist, we have an exercise trainer. One of my exercise trainers is just around here only. So it's a full program. It cannot be done only by diet. You need to have that full team. Patient needs to undergo that much of training, because it's not like toothbrush that teeth are in the mouth, you do it and your teeth is clean. No. The moment you drink water, you have had microorganisms. Why? Because you've opened your mouth. Because organisms are there everywhere. Similarly, regarding food also, we need to give it in a subtle way, give it in a specific way, give it in a smooth way, which is even digestible by the patient, and then monitor 3 monthly with your body composition to see how much the patient is gaining weight. So consistency, determination and integrity are the ones which will help you both, whether for losing or for gaining.
Thank you, Dr. Altamash. That was a fantastic. Yes, please.
not for this, not for
Hello,
this
ma'am.
kind of patients.
It was a very informative session. I have two questions for you, sir. First is that nowadays, in the obese population, the intermittent fasting is also getting very popular. So, what you call on that? Number one. And number two is when we put on the GLP-1 inhibitor and the patient is taking on low diet, low calorie. So, they sometimes develop ketoacidosis. So, how to prevent it, and what are the precaution we can take when the patient is on GLP-1?
Superb. I think both are very important, clinically relevant question. Your first question was about intermittent fasting. So when we're looking at an obese patient, and you're looking at weight loss, we're looking at cutting down the calories. Now, whichever method you use, it has to cut down on the total calories by at least 400 to 500 calories per day. If your patient is doing IF and the patient is eating more in the morning and more in the evening, and the total calories of 24 hours have crossed, for example, 1400 that you have set, then he will not lose weight, even if he does IF for full 3 years together. So better than doing IF daily, it's good that you do a calorie restrictions for 5 days and 2 days of IF so that the life is sustained. IF should not cause weakness, IF should not cause dehydration, IF should not cause fatigue by evening. That's why IF is not for everybody. Sometimes different types of diet can also cause a rebound hepatic glycogen enhancement, so which is again going to be bad for your increase in diabetes. So look at reducing calories by whichever way is healthier for patients. Your second question was GLP-1 RAs and DK. It is present, yes, we know that, euglycemic. It is also reported with tirzepatide, which is both the GLP-1 RA and GIP. So here you need to tell the patient that these drugs, they reduce the appetite by 30 to 40%. The centers for appetite, hunger and thirst are next to each other. So when the appetite has gone down, the patient forgets to drink water. That makes them go into dehydration. So that's why they should not just look at the food, they should also look at the water intake. Once they've had a regular intake of water, it is unlikely that they will have a dehydration and a euglycemic ketoacidosis. Because the first treatment that we do for that is supplementing with fluids or supplementing with water. So very important remark that we need to say is hydrate well. And if the patient is on a drug like an SGLT2 inhibitor, then hydrate and hygiene both to be done simultaneously. Thanks.
Thank you, Dr. Altamash, and a very highly interactive session, a brilliant audience. Thank you all, and thank you so much for the organizers for inviting me. Thanks a lot.